Hi everyone, welcome back to this short tutorial from Pathology Made Simple at ILovePathology.com. In continuation with the series on diabetes mellitus, this is the part 5 where we'll be discussing about the clinical features of diabetes mellitus. If you are here for the first time, I would suggest you to watch my earlier 4 videos on diabetes where I have discussed about the classification, the glucose homeostasis and the pathogenesis of type 1 and type 2 diabetes mellitus. So, in this session, let's learn about the clinical features of type 1 and type 2 diabetes. Particularly, we'll try to understand the concepts behind the classical triad, that is polyuria, polydipsia, and polyphagia. And we'll also look into the acute metabolic complications of diabetes. A quick recap of what we had learned earlier. We know that diabetes is broadly categorized into type 1 and type 2. Type 1 is more often an autoimmune disease where there is islet cell destruction. And that's because of the immune effector cells which reacts against our own beta cell antigens. You have genetic and environmental factors. Whereas type 2 is more complex disease where there is no evidence of autoimmune disease. Here also you have interplay of genetic and environmental factors, but there is also pro-inflammatory state which we have discussed earlier. The major differences between type 1 and type 2 diabetes in terms of clinical features is, the type 1 diabetes most commonly develops in childhood. It manifests at puberty and progresses with age, whereas type 2 typically seen in obese patients who are often older than 40 years of age. Of course, it can be seen in children and adolescents. And we know that there are three distinct stages of type 1 diabetes mellitus: stage 1, stage 2, and stage 3. Stage 1, all these stages you should demonstrate the presence of two or more islet auto antibodies. Stage 1 is usually, pre-symptomatic one, pre-symptomatic type 1 diabetes mellitus, where the glucose levels are normal. Of course, there will be autoimmunity positive because you demonstrate the presence of islet autoantibodies. Whereas stage 2, there is progressive loss of beta cell mass, which results in dysglycemia, impaired glucose tolerance levels. That's called as pre-symptomatic type 1 diabetes mellitus. Whereas stage 3, when there is more than 90% of the beta cells being destroyed. This is a stage where you have symptoms. The symptomatic type 1 diabetes is usually seen in stage 3, where there is very characteristic features of polyuria, polydipsia, polyphagia, and ketoacidosis if it is not controlled. We will be discussing predominantly about these things in today's session. Okay, so we should also know that the stage 2 to stage 3, the transition can be abrupt at times, usually brought about by superimposed stress, particularly infection, because there is associated increase in the insulin requirements during these stressed conditions. Type 2 diabetes, in contrast to type 1 diabetes, very rarely, they can manifest with unexplained fatigue, dizziness, or blurred vision. But the most frequent way of diagnosing type 2 diabetes mellitus is, it is often made after routine blood investigations in asymptomatic persons. So the classical triad what I am talking about is seen in type 1 diabetes mellitus. It is usually a feature of type 1 diabetes mellitus where you have polyuria, polydipsia, and polyphagia. So let us understand in detail about the mechanisms underlying these three classical features. So let's begin with insulin deficiency leading on to hyperglycemia. This is what happens in type 1 diabetes mellitus, right? So we know that there is hyperglycemia, and this hyperglycemia results in increased filtration of glucose in kidneys. So when the increased filtration of glucose exceeds the threshold for reabsorption by the tubules, that is when you have glycosuria. That means you excrete glucose in urine. So along with glucose, water also is being excreted, and that's the reason for osmotic diuresis, right? And this osmotic diuresis is what we call as polyuria, right? So you have polyuria as the initial manifestation in type 1 diabetes mellitus. Because of osmotic diuresis, it leads to loss of electrolytes and water, right? And we know that there is hyperglycemia, and this hyperglycemia results in hyperosmolarity, increased solutes in the blood, right? So because of hyperglycemia, there is hyperosmolarity, and because of osmodiuresis, you have loss of water and electrolytes. See, the combination of these two, the hyperosmolarity and loss of water and electrolytes, is the one which triggers the osmoreceptors of the thirst centers in the brain, and that leads to intense thirst in these patients. So they often want more and more water to be consumed, and that's the mechanism, underlying mechanism of polydipsia, where there is intense thirst leading on to increased consumption of water. So this is polydipsia. Now, we know that insulin deficiency is a state of catabolism. It's a catabolic state, right? So there is catabolism of proteins and fats. So let's talk about catabolism of proteins, which leads to releasing of gluconeogenic amino acids. I mean, once the proteins break down, it breaks down into amino acids, right? And these amino acids can be gluconeogenic or ketogenic amino acids. So what happens when there is gluconeogenic amino acids and when they go to the liver, they result in gluconeogenesis, which means more and more glucose is being formed, right? So the energy is being derived not from the food intake, it is because of the catabolism of proteins. Like, there is breaking down of our own proteins and fats for energy and not what we consume. That means the energy used by the body is greater than the energy taken in through the food. And this state is known as negative energy balance. The body feels that, there is not much energy being happening. So it feels the need of having or consumption of more food. That means it increases appetite, and this results in polyphagia, right? So that completes the triad of polyuria, polydipsia, and polyphagia. Even though the patient consumes more food, even though the patient is having increased appetite, remember, this being a catabolic state, that means insulin deficiency being a catabolic state in type 1 diabetes mellitus, in spite of polyphagia, the patient continues to lose weight. So polyphagia and loss of weight is a paradox. So whenever you come across patients with polyphagia and loss of weight, think about diabetes mellitus, particularly type 1 diabetes mellitus. So let's talk about catabolism of fats. What happens when there is catabolism of fats? That leads to increase in the free fatty acids. And this free fatty acids esterifies into fatty acyl CoA in the liver, where it oxidizes to form ketone bodies. Right? And because of increased ketone bodies like alpha hydroxybutyric acid and acetoacetic acid, it results in ketonemia and ketonuria. So you have increased ketone bodies in the circulation, and you also have this hyperosmolarity and osmotic diuresis. Okay, there is intense dehydration happening here. So the combination of dehydration and the ketonemia and ketonuria is what which results in the acute metabolic complication in type 1 diabetes mellitus, that is metabolic ketoacidosis. Okay, so that is the first and the acute metabolic complication in type 1 diabetes mellitus. So this is basically we are looking at classical triad and metabolic derangements in type 1 diabetes mellitus particularly. So how do you recognize diabetic ketoacidosis? What are the clinical features of diabetic ketoacidosis? Firstly, the patients might present with fatigue, nausea, vomiting, severe abdominal pain. Nausea and vomiting is because of increased presence of these ketone bodies, which starts irritating the gastric mucosa, resulting in nausea and vomiting, and also the abdominal pain. Patients, because of exhalation of acetone, that imparts a very characteristic fruity odor in these patients. And as a compensatory mechanism of acidosis, the patient starts breathing very rapidly, gasping and deep, and this is labored breathing, which is referred to as Kussmaul breathing, which is named after German physician Dr. Adolf Kussmaul, who was the first person to identify this kind of breathing in complicated type 1 diabetes mellitus. Okay, so as I told you, this is a compensatory mechanism in response to metabolic acidosis. You have lots of carbonic acid in the blood. That it has to be exhaled out, and that's the reason why patient tries to compensate more and more rapid breathing, to push out carbon dioxide, and then at least it can elevate pH in the blood. That's the compensatory mechanism which I am talking about. So it can also result in depressed consciousness and coma. Of course, that's a late complication. That's because of severe dehydration, acidosis, and various electrolyte imbalance, particularly that of sodium and potassium. So these are the clinical features of diabetic ketoacidosis, which occurs in type 1 diabetes mellitus. So when I say that, we also mentioned that the frequency of metabolic ketoacidosis or diabetic ketoacidosis is very low in type 2 diabetes mellitus. Now, why is that so? That is because in type 2 diabetics, you have higher portal vein insulin levels. The reason for that is the patient still retains some amount of pancreatic beta cell function, and insulin is being secreted, right? And that is seen in higher concentration in the portal vein, and that limits the hepatic fatty acid oxidation. It means there is the formation of ketone bodies are restricted in type 2 diabetes mellitus, and that is the reason why the frequency of diabetic ketoacidosis is very low in type 2 diabetes mellitus. Now, having said this, does that mean that diabetic ketoacidosis does not occur in type 2 diabetes at all? Not really. It can occur, particularly when the patient is having very, very severe stress. Stress, when I say stress, it is probably due to serious infections and trauma. Now, what happens when there is severe stress? That leads to increase in catecholamines, particularly the epinephrine, and this epinephrine it blocks the residual insulin action. As I told you, there will be some amount of beta cells being normal and that can secrete insulin, and this insulin action is blocked by this epinephrine, and it also stimulates secretion of glucagon. So that means there is decreased peripheral utilization of glucose because of blocking of insulin action, and it also increases gluconeogenesis, which means to say that there is exacerbation of existing hyperglycemia. So the blood glucose levels keep on increasing. It's around 250 to 600 milligram per deciliter, which can still result in osmotic diuresis and dehydration, which is basically a ketoacidotic state. So you can expect, diabetic ketoacidosis like state even in type 2 diabetes mellitus. If you don't see a diabetic ketoacidosis in type 2, so what is the acute metabolic complication which you can expect in type 2? That is, imagine a patient who is elderly and with stroke, or if the patient is severely infected, where the patient is unable to maintain adequate water intake. So what happens? Patient is already in chronic hyperglycemia, okay, which results in sustained osmotic diuresis. We have understood the mechanisms for that, resulting in severe dehydration. Now, the patient is having severe dehydration, and because of his underlying condition, whether it is stroke or infection, he is not able to maintain adequate water intake. Okay, and this dehydration continues, leading on to impairment of mental status. And there is increase in the glucose levels, and this state is referred to as hyperosmolar hyperglycemic state. Okay, so the hyperglycemia is usually more than what we see in diabetic ketoacidosis. It's more than 600, and it can go up to 1200 milligram per deciliter. Okay, in the end stages of this condition, they might go in for impaired consciousness and even coma. That is hyperosmolar hyperglycemic coma. Okay, this can happen as an acute metabolic complication of type 2 diabetes mellitus. Now, how do you say that this is not diabetic ketoacidosis? Because there is no formation of ketone bodies, right? There is no catabolic state here. There is no formation of ketone bodies, no Kussmaul breathing, no fruity odor. So that is why it is often difficult to identify hyperosmolar hyperglycemic state until the patient manifests with impairment of mental status. So this is about the acute metabolic complications what we see in type 2 diabetes mellitus. So that's all for this session. We have talked about clinical features of type 1 and type 2 diabetes mellitus. Particularly, we understood the concepts behind polyuria, polyphagia, and polydipsia, and we have seen acute metabolic complications of diabetes. Thank you for watching. If you like this video, hit the like button. Do comment if you have any queries to ask. And also, if you want to say what topics should I be covering subsequently, please do comment. If you feel this video useful, consider subscribing and please do share. In the next session, I will be talking about chronic complications of diabetes mellitus. Stay tuned. Bye bye.